the problem of opioid addiction is well recognised in the US, where opioids are reckoned by the CDC, this is the latest information I've got, to have caused the death of over 300,000 people since the end of the 90s. But it's really been a sleeper here in the UK until very recently. However, a paper published last week in Population and Development Review on the US situation states that, quotes, similar and troubling signs are already discernible in Australia, Canada, and the United Kingdom. Two big reviews are now underway in the UK. Public Health England's review of prescribed meds that may cause dependence or withdrawal, which started early in 2018, includes opioids and will report in June, July. It was going to report earlier, but they tell me that it's now not going to come out until June or July. The MHRA has recently launched a review of opioids, and I put details, links in the handouts, together with some other bits and pieces I thought you might be interested in, including the reference to this book, which is the most amazing background to the whole thing and really details it in the most vivid terms. It's a big subject, and we have limited time this evening because there's a Zumba class after this, so let's start dancing. We have to be out at about 4:48. So, as well as an overview of the problems, we're particularly focusing on the emerging concern of users who resort to buying these prescription drugs online through various methods, and also the lack of provision for addicts who want to stop and then encounter withdrawal problems. This topic came about during a conversation I had last year with Dr. Owen Braden-Jones, who called it an emerging health crisis. I was particularly struck by it because I'd been prescribed tramadol in 2002 for pain from a serious accident. When I stopped taking it, I spent a year dealing with the appalling withdrawal symptoms, which included suicidal thoughts. I've written some notes on what it felt like, and they're included in the bits of bumps, because I just didn't want to go about it now, but I thought it might be useful for you to know what it feels like. So we've got three speakers this evening, Dr. Owen Braden-Jones, Dr. Kathy Stannard, and Linda Scammell. We're going to start with Dr. Owen Braden-Jones, who's a consultant psychiatrist and chair of the Advisory Council on Misuse of Drugs. And he's founder of ATOM, the Addiction to Online Medicine Service in London, which is run by the Central and North West London Trust, who are our hosts. So, Owen.
Thank you. Okay, well, I'm very much pleased to be talking about this issue. I think this is a really interesting, challenging, complex issue, and I very much hope I'll be able to set the scene for the next two speakers who will talk in much more detail. I'm going to start by introducing you to Anna. So Anna's one of my patients, currently in treatment. She's 26, she's an account manager, and she lives with her friends in West London. She has a previous history of using drugs, recreational drugs, so she has, during her time at university, used cocaine, MDMA, ketamine, and of course alcohol. But much of that really stopped and fell away when she moved to London, started her job, and other things took over. She has had one period of depression when she was at university. She saw a counsellor, felt much better, and after 5 sessions she felt she'd made a full recovery, and that's her only sort of mental health history of note. She's got no family history of addictions, she's got no family history of any other mental health problems. She really likes her job, she enjoys it, but she does find it stressful, and she describes also really burning the candle both ends. So she's got a busy work life, but also what she describes as a hectic social life. She's a very engaging, very sort of dynamic sort of young woman who's sort of really excited to be in London and really excited about her future. Now, during a period of work stress, Anna experienced insomnia. She was worried about deadlines, she was worried about her performance, and so she had several weeks of really not being able to sleep and felt that this was continually building into a problem and impacting on her but both her work performance, but also her social life. She went to see her GP, who said, okay, well, let me see if I can reset your sleep pattern. I'm going to give you 7 days of Zopiclone. Here are 7 tablets. So she had a prescription for 7 tablets, and off she went. The tablets worked very well. They helped her sleep. She started sort of feeling much better. But when they finished, the insomnia came back. She, at her GP's suggestion, tried other approaches. So she tried to exercise, she tried some hypnotherapy, she also went to Holland Barrett and tried some different homeopathic remedies. All of those really didn't help. And so she was left with this sense of going to bed and worrying and not quite sort of being able to fall asleep. Now, in the past, Anna had used Nurofen Plus for headaches that she experienced during university, and particularly during stressful periods when she was revising for her finals. And she remembered this, and she also remembered that when she took them, they helped a bit with sleep. So she went to the chemist, and she got some Nurofen Plus, and she took them, and they made her feel much better. They made her sleep better, but they also made her feel much calmer during the day. So that work became a little bit easier, a little bit less stressful, and she was aware that, you know, the medicines they had to be a bit careful of. She was aware that they had the potential to become a problem, but she felt she very much had it under control, and that in the short term they were a very reasonable thing for her to do. And the chemist, her local chemist, who she had a really good relationship with, she said, you know, I go to my chemist for everything. It's much easier than going to the GP. You go to the chemist and they tell you what you need. And this chemist said, okay, we'll take these, but in the short term. Over the next month, what she noticed was her use began to increase. She was using them every day. 1 tablet a day turned to 2 tablets, turned to 3 tablets. She became a bit concerned about the escalation, and Anna told me that she tried on a number of occasions to just cut back. But when she cut back, she felt terrible. She didn't sleep, she felt irritable with her friends, she felt that she couldn't work, she couldn't concentrate. She had 3 deadlines due the following month, really important ones that her pay progression depended on. So she thought, I'm just going to have to keep taking them for the moment. And then once the deadlines are done, I'm then going to cut down and stop this. Unfortunately, the deadlines came and went. She got the work done. She felt that it was time to cut them down, but she didn't. She kept using the Nurofen Plus. The dose kept going up. And she became actually a bit embarrassed about going into the local chemist, because the chemist began to say to her, I don't think you should be using this. But rather than stop, she thought, I've just got to find somewhere else to get them from. So she went online at the suggestion of a friend, and she was really surprised that she could go online and within a couple of minutes find a website that would sell her not just Nurofen Plus, but would sell her codeine, which she knew was the ingredient in the Nurofen that was actually really helping her. So she thought, well, okay, I'm just going to buy some of these just to tide me over. The other thing she noticed was it was a lot cheaper to buy online than it was actually to go down to the chemist. And so she ordered 200 codeine tablets, which arrived the next day through the letterbox. I don't know if you can see this, but it's got 2 different strengths at the top, 30 or 60 milligrams, and then it's got a variety of different amounts you can buy, up to 200. And through they came, she opened the packet, and there were 200 codeine tablets. So she'd already moved to a medicine that was now stronger than the Nurofen Plus that she was using to start with. That was in 2016. And unfortunately, it took until 2019 until Anna actually came and asked for some help. So what's happened is that she's been using codeine continuously since then, every day. Her dose has increased very, very dramatically. She describes the classic symptom of tolerance that you see with dependence, where people need to use more and more of the same dose just to experience the same effect. So she's now taking about 10 codeine tablets a day, and she takes her first tablet when she wakes up in the morning. She absolutely recognises that she's addicted to these tablets. She's recognised it for a number of years, but she just hasn't been able to do anything about it. And then she read about the new service we launched, the Addiction to Online Medicine service, in a paper, and she thought, I've got to get this sorted out, because it's 10 tablets now, it's going to be 20 if I don't stop. One of the main barriers, interestingly, to stopping her to seek help was her embarrassment. She said, I can't go and talk to my GP, because what am I going to say? That I bought all these tablets online rather than coming to see him? She couldn't go and talk to her pharmacist because she'd been avoiding him because he'd warned her about this, and now she was stuck in this situation. And so her embarrassment about her use was one of the major barriers to her seeking help. So nobody knew. She was ordering all of these things and nobody knew. Her parents didn't know, her friends didn't know. She was just getting these packages coming on a regular basis and nobody really knew anything else about it apart from her. Okay, that's Anna, and I'll tell you a little bit more about what happened to Anna a little bit later on. I'm not going to spend too much time talking about opioids because there are some opioids experts going to speak next. So I'll just very quickly say that essentially we're talking tonight about a group of medicines which are chemically really quite diverse, but what they share is a common feature of where they work in the brain. So they work on the opioid receptor in the brain. And that's how they mediate both their analgesic effect, which is how they're usually prescribed, but also some of the desired effects of people who misuse them. The sense of relaxation, sometimes a sense of just things being a little bit easier, of things being a little bit less stressful. As you probably know, there are a range of different opioids. So we've got everything from something like codeine or Nurofen Plus, right through to super strong opioids, things like fentanyls. And what determines how strong or weak an opioid is how strongly they bind to those receptors in the brain. So how big is this problem? How big is this misuse of prescription medicines, particularly from my perspective, from online sources in the UK? Well, I'm going to give you an honest answer. We really don't know. We don't understand the scale of this problem, and that's one of the challenges that you'll probably hear from the other speakers as well. If you read the papers though, and I know there are a number of journalists, health journalists sitting here, you'll know that this is a story now. 6 months ago, maybe even 12 months ago, this was not a story. This is now a story. People are beginning to understand that there's something going on here, and we're beginning to see articles appearing that are beginning to question, well, what is actually happening here? You know, we talk about heroin, we talk about ketamine, we talk about legal highs, but hang on, this is a different situation. These are prescription medicines. These are, is this different? Is it the same? Well, Sarah's already alluded to the fact that Americans are ahead of us on this story. They're several chapters ahead. So the FDA have commissioned a big review. They had something called an Internet Stakeholders Opioid Summit in June last year. And this is specifically about opioids being bought online, and that's the bit that I'm particularly interested in. They produced a report from that. It was chaired by someone called Rob Portman. And interestingly, he put out something called the Portman Statement. And it's probably too small for you to read here, but this statement essentially said that the internet providers need to start thinking about their moral obligation in terms of what they are making available to the general public. And that actually you could think about pharmaceutical companies and you could think about blaming people who are buying these tablets, but actually there was a gap in the middle, and it was about the people who are providing the sites where these online pharmacies sit. So that may be something that we can come back to in the discussion. Now, this story is very different in different parts of the world. So the US story is now becoming better understood. But when you move outside of North America, it's a little bit less clear. So we know there are large global variations in the number of people who, or the prevalence of online medication misuse. The United States, their evidence shows that something like a quarter of 18 to 25-year-olds have at some point bought something online that they're not meant to have, a prescription medicine. So a really very high percentage. In Europe, what evidence we do have suggests that the pattern is slightly different, that actually the preference in Europe is more for benzodiazepines and stimulants, and opioids appears to be an emerging phenomenon compared to the other two. It also appears that the culture of buying online is less developed in Europe than it is in North America. But again, that might be changing really quite rapidly. If you come to the UK itself, again, we're really struggling with evidence. We're really struggling with understanding the data here. There are some articles. This is an article just recently produced on crypto markets, and this is looking at who's buying what online. The UK looks to be about the second largest market for online purchases. Certainly of benzodiazepines, it's not quite clear yet about opioids, and we may hear more of that a little bit later on, but certainly the UK is seen as an emerging market for online sales. And then there are other things like the Global Drug Survey, which is an international survey of people who use drugs, and again, really quite high rates of prevalence reported by UK users for purchasing online. Now, what we do know from the North American evidence is a little bit about which groups are more likely to buy online. So, men are more likely, young people, students, people who define themselves as clubbers, and then men who have sex with men. Those are the groups that the evidence so far shows are particularly likely to go online and buy something, buy an opioid. We also know some of the associations with buying online, and those are mental health problems, post-traumatic stress disorder, and other drug use. So again, those are very common associations with people who are purchasing medicines online, particularly opioid medicines. So we're beginning to build a picture of the type of person who may be particularly vulnerable to this problem. Well, what about treatment? Well, I'm going to tell you a little bit about a service that I run called a Club Drug Clinic, which has evolved over some time. It was actually opened in 2010, and it was opened then because what we found was there was a group of people using drugs who weren't using heroin, who said, well, if I'm not using heroin, I'm not going to a heroin service. Because back in 2010, most drug services were predominantly working with people who were using heroin and crack cocaine. But this newer group of users were going, well, I don't use heroin, I don't use crack cocaine, I'm using ketamine, or I'm using a novel psychoactive substance. And I don't think I really fit there, and I don't think that service really knows very much about the drugs I'm using. So I'm not going to go. And so in a way, that's why we set it up. We had a small number of club drug users presenting to our, at the time, a heroin service, and they were really very different. They were in work, they had friends, they had social networks, they were psychologically minded, they didn't define themselves by their drug use. They were different to the heroin using cohort that I was seeing at the time. And they really didn't like sitting in the same waiting room. There was a very interesting sort of reverse stigma around this group to heroin users. We also were getting calls back in 2010 from HIV services, accident emergency, mental health wards, all going, we've got a group of patients, they're using drugs, but they won't come to your service. And at the time there was a shift of younger people, and continues to be a shift of young people away from heroin. The heroin message seems to have got through to young people. They don't want to use heroin, but they've got a Pandora's box of other things to try instead. One thing that was very clear, almost straight away, was that every one of our club drug users had a smartphone. They had the latest iPhone. They would show us their latest iPhone with sort of great glee. They were very technological. They were on social media. They were on apps. Everything they did was online. And so that allowed us to take an approach to try and engage them. So back in 2010, we used these QR codes, and we put them in the toilet cubicles of clubs around London and allowed people to scan them and refer themselves to the clinic on their phones, often when they were quite intoxicated, interestingly. We also realised that this clinic, if it was going to be successful, had to operate in the same sort of space. It had to have an online presence. It needed to have a website. It needed to have a way of engaging with people on the platforms that they were using to buy their drugs. We needed to be able to recommend apps to people, to say, you're going to sit in your assessment with me now, and we're going to get you to download this app onto your phone right now, so that you can use it when you need it later on. And so we started to use some of the technologies that they were already using for other things. When we started, people were buying what was at the time called legal highs. And they were buying it either from the dark net or from the clear net before those sites all closed down. After about a year or so, it became less about legal highs and it became more about buying illicit drugs. So people would now buy their GHB, they buy their cocaine, they buy their MDMA online. It then moved from websites onto social media apps. So this was about 2 or 3 years ago. People started saying to us, oh, we don't go onto websites anymore. We go onto WhatsApp or we go on Instagram, and that's where we buy our drugs now. And any of these encrypted platforms, they were going, these are great because they're encrypted. Nobody can see them. We can do whatever we like. We can, we can buy, sell drugs. That's the space we're in. And then most recently, about a year and a half ago, we heard people saying, well, actually, we don't just buy our drugs online anymore. We top up with medicines. So, we'll go out, we'll have a weekend, we'll use cocaine, and actually, it's quite nice to have a little bit of Valium at the end of a weekend. So we buy that online as well. And so what became apparent to us was there was this whole subculture of people procuring a range of psychoactive drugs online in a space that we weren't even aware of. So why do people buy online? I mean, what's the attraction of that? Well, in terms of buying medicines online, I mean, because we said to people, we said, well, why don't you go to your GP and ask for some diazepam? I said, we have to wait 3 weeks to see a GP, and we're going partying this weekend, so we need something a bit more immediate. So the first advantage was they didn't need a medical consultation. So that was good. They needed no prescription. They needed it fast. They wanted it the next day. They order anything on Amazon, it comes within 12 hours. And they wanted the same sort of service for their drugs. They wanted the convenience. They didn't want to have to go to a GP or go to a pharmacy. They wanted it to come through the letterbox so that they could just open the package and it would be there for them. They wanted it to be confidential, so they appreciated the encryption, and they wanted to be cheap. So rather than paying a prescription fee, they could order 500 diazepam tablets for the same amount. And then they could sell a few to their friends or give a few to their friends. And so they said, well, this is also great value. So what about some of the harms? Well, of course, the problem with no medical consultation is, these are prescription-only medicines for a reason. They can be harmful for people. They interact with other medicines. So you have no process of understanding what that might be without a medical consultation. The other thing is some of them are counterfeit. They're not actually the medicine at all. They're either chemical duds or they're a substitute drug put in the tablet and sold as that tablet. There are also often adulterants in, so there might be quite harmful chemicals mixed in with these drugs. And so nobody really knows. You don't really know what you're getting when it comes through the letterbox. And perhaps the most interesting thing was this perception of safety. people said, well, it's a medicine, it's going to be fine, you know, it's come in a blister pack, how harmful can it be? And they sort of were very dismissive of some of the potential risks of buying things online because it looked quite legitimate. And so that legitimizing of a blister pack was a very interesting early feature. So for all of those reasons, we set up the online Addiction to Online Medication Service, or the ATOM service. It's been running about a year. So far, we've seen obviously a lot of online purchasing, but the main drugs we've seen so far have been benzodiazepines. We've seen some people buying cognition enhancers, things like pregabalin, Ritalin. We've seen some people buying opioid medicines, things like tramadol, codeine. And what's interesting is when I look at the profile of people who are coming, what we tend to see is that people are using illicit drugs and mixing them with prescription drugs. And so although we do see some people who only use prescription drugs, most people are actually blending a bit of everything, and they're using a little bit of diazepam if they need it, or a little bit of codeine if they need it, and it's just broaden their repertoire of psychoactive substance use. I'm nearly finished now, but just two innovations that are happening at the clinic. One is called Atomic, and this is actually some funding we've received from the Health Foundation to develop an app for clinicians to try and educate them about some of these new trends. And so again, trying to incorporate the technology that's already been used through social media by developing things that go on people's mobile phones that can help educate them about some of the risks. At the moment, this is very much aimed at frontline health professionals, but we are having a think about whether we do something for patients as well. And the other one, if you want to be really geeky, and I know some journalists actually do get properly geeky about this sort of stuff, so we have produced a fairly slim, it's about 20 pages, monograph on the dangers of fentanyl and analogues, so synthetic opioids, harms, some of the treatments. And if you want a very easy to use reference around some of the harms, emerging harms, some of the treatment options, then that's available on the Neptune website, so Neptune Clinical Guidance, and that was published at the end of last year. Okay, final word about Anna. So Anna arrived this year, entered treatment severely dependent on opioid medicines. She lost her job as a result of her drug use. She needed a 1-week medically assisted detoxification. She had intense cravings for opioids in a way that you would see with a typical heroin user, and actually needed anti-craving medicines and very intensive psychological treatment. She's now been without drugs for just under 3 months. And is actually optimistic. I mentioned her sort of quite engaging personality. She's very keen to get back to work, feels that she's going to be able to put this behind her, and sort of says, if you ask her, she will say, well, you know, I sort of did know this was not a very good thing to do, but it just seemed so easy. It was just sort of, there was always an excuse not to do it that week and to put it off and buy a few more, and it just sort of happened. And so that's how she would describe it, and she would describe it as something that both she and many of her friends she feels would be vulnerable to. She said, this is not something that I don't feel like a hardcore addict. This is something that could easily happen to any of my friends because it was just so legitimate. I'm going to leave it there. If you want to know any more about the Club Drug Clinic, that's the address there. That's the Neptune Clinical Guidance. If anybody wants to contact me, my email and Twitter account. Thank you very much.
Thanks so much, Owen. That was fascinating. And now we have Dr. Kathy Stannard, and who's a consultant in pain management and an opioid specialist. And when Owen and I were first talking about this and planning it, he said, we were talking about other speakers, he said, if you can get Kathy Stannard, she would be the best. So here we are, and we're absolutely delighted that she's with us. Kathy is an expert on opioid medication and has also done some very interesting research in how effective or not opioids are for whatever indications. And also, I think is going to give us an overview of what she's doing with her own trust in Gloucestershire.
Thank you, and it's a huge privilege to come here, and I'm a little bit worried that I've been bigged up more than I should be. And I'm going to tell a slightly different story. It's another kind of facet of this opioid story that I think helps to understand the complexity of this space. And so some of this is a bit historic, and I just wanted to draw some lessons out as well between what's happening in the United States and what's happening here. Because I think we do have a public health problem, but it may not be actually coterminous with what's happening in the States. It may be a slightly different but overlapping problem. So obviously Owen and I read some of the same newspapers, so these are some very typical recent articles about how we're in the grip of a opioid addiction. I would draw your attention to another couple of articles which I think speak to where I'm going today, which is not quite we are in the grip of an opioid addiction, but we are in the grip of using opioids problematically. And if anybody wants the links to either of these, I can give them. The top one was in The Guardian about 3 weeks ago, and a couple of days before, Britain's everyday drug problem from a new media startup that you may have heard of called Tortoise. And I have some slides from Tortoise's work a bit later on. So I'm just going to say a little bit about global opioid conversations, and then I think the knotty bit of this is that these drugs are painkillers, and actually pain is maybe not what we think it is. And if I've got time, I will tell you about some of what we're doing in Gloucestershire, but we can maybe cover some of that in the Q&A as well. And I won't do all the slides for that, but I'll just say what the thrust is. So I think there are different conversations going on around the world, in North America, UK and Europe, and I want to say just a word about low and middle income countries, because I think that's a space that gets forgotten in this conversation. And we've heard from Owen, we know about the widely reported US opioid crisis. It's not just about increasing prescriptions, there are a whole load of antecedents to this. So it started off with the idea that it was against people's human rights to die of in pain with cancer, which is very reasonable. But then there was a philosophical discussion about whether it mattered what the cause of your pain was. So it became that any sort of pain you had, you should be allowed to have strong painkillers. And there are a huge number of initiatives to reduce pain in America. And pain became the fifth vital sign. And there are huge pushes from patient advocacy groups, often funded by the pharmaceutical industry, to demand that pain be ameliorated. As we know the story about the aggressive and irresponsible marketing of oxycodone in particular, with the risks of addiction being minimised. And there was a paper in 1980 which looked at 12,000 patients in Boston who had been treated with opioids for short-term pain, so fractures, falls, whatever. And out of those 12,000, 4 became addicted. And that paper gained huge currency. It was a small paper, it was a letter of the New England Journal of Medicine, and it's recently been retracted because it completely misrepresented the addiction potential for these drugs. I think we then started asking questions about evidence, and when I started doing pain in about 1066, the message was that opioids didn't work for chronic pain, so we shouldn't use them. But towards the end of the 90s, a lot of drug company evidence came out, low quality evidence suggesting that these drugs might be helpful for long-term pain. And so they became more liberally prescribed. And in parallel with increasing prescriptions, they're escalating harms. So we reappraised the evidence and we realised we'd been led down a wrong path, as early trials were poor. But what it has resulted in a critical appraisal of the role of opioids in pain management now. And I think whatever has happened in the States, whatever is happening here, it is very useful that opioids are viewed under this high-powered lens. These figures, again, will be familiar. This shows that actually we're not the biggest sinners in Europe. There are other parts of Europe who prescribe more liberally than we do. We use about a quarter of the opioid load per capita to the United States. The United States contains 5% of the world's population and prescribes 80% of the world's opioids. And as we've heard, the number of patients who die of drug overdoses now exceeds car accidents, guns, and HIV has obviously gone right down. And I think the figure that I read was that approaching 1 million people who have died of prescription opioids. And one person dies of a prescription opioid every 7 minutes. So by the end of this talk, many lives will have been lost. And I think this is very important. So this is the 3 waves, and I think we should take note of this. So as the initiatives to bite down on prescription opioids began to work, in about 2011-12, users changed over to heroin. And then as initiatives to control use of heroin began to bite much more recently, other synthetic opioids that we've heard about from Owen just absolutely rocketed. And these are very, very potent opioids. And you don't have to have a field in Afghanistan with insurgents coming in and people in helicopters. These can just be made in labs, often in China, and as we've heard, just be sent through the US Postal Service. And there are now 258 really potent analogues of fentanyl, some of them extremely dangerous, so first responders on the scene, if they touch a supply, they can die. These are very, very potent drugs, often have a background of using to immobilize large game in animal reserves and so on. So these are very, very potent. And they are made up, as we've heard, they're made up into look-like safe pills. So there's a thing called a shady 80. So 80 is the commonest dose of oxycodone, and fentanyl is made to look like oxycodone, but of course one of those tablets will probably kill you. So it is a huge problem in North America at the moment. There are some differences. If we look at past month illicit drug use in the States, prescription pain relievers come second to marijuana in the choice of drugs. And if we look at Europe, we find that opioids are actually quite low down the list compared to other drugs, but obviously are responsible for a large proportion of deaths because of the hazards associated with heroin use in particular. These are data from the most recent crime survey of England and Wales. You will see that there are differences in use across the age range here. So the red line is males, all illicit drug use. The blue is females. Tends to decline with age, as we'd imagine, peaks late teens, early 20s. Prescription drug misuse stays pretty steady, and if anything, increases with age. So quite a different pattern of misuse, suggesting different users and different reasons for misuse to other other illicit products. And interestingly, in the crime survey, we reckon 6 or 7% of people have used a prescription medicine not prescribed for them in the past year. But of those, about 98% of users do it to treat symptoms of their own. So it's not to get high and it's not to feel different. Most people who use prescription medicines in this survey used it to actually treat a medical condition. And deaths related to drug poisoning, again, the vast majority of deaths are related to heroin and morphine, morphine being metabolite at post-mortem of heroin, and methadone, which is obviously used to treat substance misuse. And just expanding up the bottom of there, you can see that tramadol had a peak a couple of years ago, but I think the rescheduling of tramadol has probably been responsible for fall off in tramadol deaths. And if we just look at that yellow line at the bottom, chugging along, you can see there's an uptick in fentanyl-related deaths, and we don't really yet know where that is going. But I think it's important to say that largely that is not prescription fentanyl, it is illicitly manufactured fentanyl, largely coming in through the post from China. And it's a particular problem in the northeast. These are figures that actually bear out what Owen said in his presentations. These are figures from the National Drug Treatment Monitoring Service. So these are data from publicly funded substance misuse services, and they show that about 4% of the population in treatment are using prescription medicines, and they're divided roughly between people who, as we've heard, are using them as part of a polysubstance misuse and people who have prescription drugs as their sole drug of dependency. This speaks a bit to what we heard at the beginning, that this journey, these are American data again, can often start with regular prescription for pain in the short term. And what we know is that if you are prescribed more than 5 days supply of medicines, your chances of getting stuck in a long term jump significantly, and if you are given more than one prescription. So we really need to be very, very careful how we're treating people who come into hospital. And I'm not going to go through this, but there are quite a few protective factors in the UK that make the situation somewhat different to the US. So the publicly funded healthcare system, GPs are great gatekeepers. They know who's taking what most of the time. However, this is where the online use may emerge. There's no direct consumer advertising, and there were many cases in the States of physicians being sued for under-treatment of pain, and there have never been any cases at GMC of somebody being sued. There are plenty of complaints that go to the Ombudsman about under-treatment of pain, and very responsible clinicians restraining themselves and exemplifying fantastic practice, but a lot of those end up at the Ombudsman, but very few are helped. And there is very little, much better access to opioid substitution therapy in the UK and the States. This is a good book, and there are many similar stories, but Taking America Off Drugs, Why Behavioural Therapy is More Effective for Treating ADHD, OCD, Depression, and Other Psychological Problems. America has been described as a psychopharmaceutical society. And one word about low and middle income countries, that this is a really nice paper about bridging the access abyss in palliative care. So you can see that these map has been blown up depending on availability of opioids for those who need them dying at the end of life. And the first figure is the milligrams per capita, or milligrams per person in need of opioids who's dying. And the second one is the percentage of need that is met. And so we look at Canada, and there are grams, and the US there are grams of opioids, so far, far in excess of what is needed. And orders of magnitude greater than the need. And then if you look at other parts of the world, very few places are getting it right. Western Europe, again, still a huge amount of overprescribing, and many countries where, however hideous pain from cancer that you have, there is no access to effective medicines. So you might have a pancreatic cancer and have to travel 6 miles in a bus to meet a nurse in a lay-by who will give you 1 dose of Oromorph, and that's it for the whole of your disease trajectory. So I don't think we must forget that, and there is perhaps a risk that when we talk about the opioid epidemic, we must remember that we mustn't disadvantage people who are genuinely in need of opioids. And not surprisingly, the big pharmaceutical companies are exploiting this space. They are now marketing opioids for non-cancer pain very heavily in the middle-income countries, and sadly they are marketing expensive opioid preparations in countries where access to simple, cheap morphine would make a difference. And this has been described as just taking a leaf out of the tobacco industry, and that's tremendously sad. So a little bit about pain. So we all have pain. A lot of us will have had pain today. We have a pain signalling system to warn us that we've injured ourselves. It usually gets better with time. We all experience pain differently, but we must interpret pain in a philosophical, cultural, religious, and personal, emotional context. And what about pleasurable pain? I don't mean SNL, I mean the sort of pain you get after you've been to the gym. So pain is not necessarily always aversive. We talk about short-term acute pain and long-term chronic pain. And the message here is that acute pain is usually associated with something obviously painful going on. And if you have a big injury, it hurts more than a little injury. And treatments, including opioids, are usually very effective. Chronic pain is a completely different entity. There may be no obvious pathological process going on. It is always described as severe. The intensity is unrelated to any tissue injury. It's probably almost impossible to treat, but it is very damaging for the individual and usurps their identity. And then there's a little bit in the middle, which is things like rheumatoid arthritis flares, which are pains that go on, but they're more like short-term pains that reappear. And they tend to respond rather better to treatments than chronic pain. So have you all heard of a 0 to 10 pain score is how we measure pain? If you describe pain as 10 out of 10, you will not respond to medicines, whether you've got cancer or not. 10 out of 10 is simply related to anxiety and distress. So the 0 to 10 scale, all that tells you in long-term pain is the degree to which you want help. So the patient comes into my clinic, I've got pain 10 out of 10, what they're saying is, I want you to help me a big lot because my life is miserable. It doesn't mean anything to do with the degree of tissue injury going on. And nothing works very well. And the analgesic ladder, which is used by a lot of people, is designed for cancer pain, but it is flawed because it prescribes on the basis of reported pain intensity. And reported pain intensity has nothing to do with tissue injury. So the more distressed you are, the more likely you are to get a strong analgesic. And that's where things kind of go quite badly wrong. Prevalence of chronic pain is closely associated with economic deprivation. And as you'll see in a minute, so is prescribing. These are the big ticket items for the NHS. This is a lot of money spent on medicines for pain. In the past year, the prescribing of opioids has slightly sort of topped out, and if anything, is slightly going down. And I think messages about prescribing opioids are getting through. If we look at where opioids are prescribed, again, very closely linked to deprivation. And these are the things from Tortoise Media. They did some interesting analyses. They controlled for deprivation and then looked to see what the map looked like. And even controlling for deprivation, there are pockets of high opioid prescribing. And the Northeast is really a very challenging environment. And if you talk to drugs workers in the Northeast and people providing services there are whole communities laid waste by misuse of medicines and illicit drugs in the Northeast. But what is interesting is if you look at regional rates of domestic abuse, sexual abuse and child protection cases, it maps over. And that is our experience in clinic, that intimate partner violence, childhood adversity, very, very common in people presenting with pain. And we did a study with the Department of Social Medicine in Bristol, and we found that 60% of all comers had had either childhood abuse or intimate partner violence. They were patients up to the age of 70. Most had spent a lifetime in medical services, and 90% of them had never been asked about adverse experiences before. And interestingly, 90% of them said they thought they should have been asked. So people don't mind being asked. We have to understand people's burdens to help them. Do medicines work? This is an analysis I did this morning. The Cochrane Database of Systematic Reviews is a nice digest of how well things work. I googled this morning, there are 500 hits for chronic pain, 152 are relevant, mostly medicines, behavioural interventions, exercise and other interventions, and basically nothing works very well. So some medicines work in about 3 out of 10 people in a clinical trial. That translates to about 1 in 10 or 20 in clinical practice. So the problem we have is that nothing really works, okay? So when we talk about using things instead of opioids, there isn't anything else to use, which is where we have a problem. The number of patients prescribed opioids in England has increased, obviously, over the decade 2000 to 2010. And if you look at those pale blue bars, almost all the prescribing has been for non-cancer pain, which is an indication for which the drugs don't work. So, we have to ask ourselves why. They don't work and they are full of harms. Why are we prescribing them? And it's because of the strongest painkillers available. And even if you say opioids should be the 10th, 20th, 100th, 500 line treatment, You will always get there because nothing else works. So you will always end up at opioids at the bottom. And actually, why do we prescribe it when we know it doesn't work? And that's because pain sufferers exhibit distress, and distress makes us want to do things. So I've seen at least 23,000 patients in my career. And if a patient says to me, so you're going to leave me in pain then? I still find that really, really difficult to mount a constructive response to that. It is wired into us as healthcare professionals to help. And patients will come pleading, you must help me. My life is a misery. It is very difficult to say, I'm not going to give you anything. So there is a generally poor understanding about how complex pain is, the fact that it doesn't respond to treatments, and that there are many, many emotional, not only consequences, but emotional things that lead to you having chronic pain. There is a lack of time and a reluctance to ask the right questions. So here we are, GP consultations in UK versus the rest of the world. 75% of consultations involve more than one problem, 42% 3, 2.5 problems in 11.9 minutes. 9 minutes devoted to the first problem, 2 minutes for each additional problem. How can you begin to get to the bottom of the complex stories behind people with pain in that space of time? And I think a lot of GPs now are, the receptionists are saying you're only allowed to present with one problem. And if you have 2 problems, you have to make more than one appointment. There's a poor understanding about what reported pain intensity means. People don't know enough about things that work and don't work, and most things don't work. This is a really key message. Doing nothing is better than doing something harmful. We have given every prescriber in our county a pen that says, first do no harm on it. And patients have tough enough lives with pain. They don't need us giving harmful medicines on top of it. So they have the pain and all the harms of the medicines, and the medicine's not working. So doing nothing is better, although it is much harder to do nothing than to do something harmful. It is very easy to do something harmful, and it is okay to stop trying. And actually we need to have a different conversation. We have different, understand pain in a different context, and we need to get the message out of there that it is not realistic to expect medicine to sort out the problem of chronic pain. All I was going to say about our Living Well with Pain programme in Gloucestershire, and I'm just going to flick through these, is if you like, our unique selling point is getting in behind that finding that prescribers know it's the wrong thing to do, but they do it anyway. So we have explored themes of transactional analysis, the drama triangle, having grown-up relationships with the patient rather than parent-child relationships that can work in both ways, going underneath our thoughts and feelings as healthcare professionals when we're sitting in a distressing consultation, and actually getting clinicians to have more appropriate repertoire of responses. Of course we've done the education, of course we've done about evidence, about efficacy, about harms. We've identified every patient in the county who's on a potentially dangerous prescription. We've had every patient in the county on a potentially dangerous prescription reviewed with a plan to make that more safe. But the key is actually changing what we think in those difficult conversations. And actually in the first 8 months of the project, we saved £750,000 on opioids, and that was simply by not prescribing them to people that they don't help. It isn't taking people off helpful opioids. Yes, we saved £750,000 in 8 months by not prescribing them to people who don't help. And I'm going to leave you with this quote, which I think is fantastic. It comes from Andrew Green, who's the BMA's Committee Clinical Policy Lead, and I'm going to read it out. We're in some danger of concentrating too much on the final act of prescribing, the pressing of the enter key and the spitting out the print of the green piece of paper. The prescribing decision is simply the end of a complex interaction between the doctor, the patient, the illness and society. And while we continue to live in a fragmented, unequal world with poor access to acute mental health services, GPs who have less time to spend with their patients than those in other comparable countries, prescribing will be higher than it might. So this is a societal and cultural problem, and we must not look at medical interventions to try and solve it. I'm going to hand over to Linda now.
Thank you. Thank you so much. Kathy, that was an extraordinary overview of calling each people here. Now, something a bit different.
Yes.
Linda Scammell is Senior Policy Manager at the MHRA. She's going to talk about the regulatory loopholes that enable online pharmacies to sell prescription drugs illegally. And just while we're waiting for dinner, I was making supper the other night, and at the same time, when my husband asked me what I was doing at the computer, I was ordering tramadol online. And I could have got it 200, 500 pills coming through my door the next day. So, Linda.
Hello and good evening, everybody, and thank you very much to Sarah and Jatinda for extending their invitation to the agency. I'm Linda Scammell and I work on the enforcement group at the MHRA. I'm sure everybody in the room knows the MHRA and what they do, but I don't know if you know that we also act as the law enforcement authority for medicines and medical devices in the UK. So we're the regulator and we do a police and border force role with the medicines. And that's where I work. Owen has already given you some examples of people ordering medicines on websites that are acting completely illegally. In the UK, the law is for a prescription-only medicine, you need a prescription. So websites that offer you a prescription-only medicine and there's no prescription on offer are breaking the law. And we spend an awful lot of time pursuing websites that are operating in that way. They're operating illegally, off the radar, and we track them down. Depending on where the website is hosted, we can do something about it. In a lot of cases, they're hosted in a country where we can't do anything about it. But I'm going to park that for this evening and talk about another problem. Now, that was referred to us because people assumed that this was illegal activity. I've been looking at it since about 2011, and I'm going to explain to you how you can go online, get a prescription-only medicine through a website, and by consulting a doctor that is completely legal. So, the process then. You're the patient and you would like to buy a medicine, including a prescription-only medicine or a controlled drug, through a website. So you say, I want to buy tramadol. You said you were going to buy, I want to buy tramadol. Now you will get hit with millions of sites. A lot of them, as I explained, are operating illegally. But some of them will say to you, okay, you want to buy tramadol. We can arrange for you to have a consultation with a doctor online. So the website will refer you to the doctor's prescribing service and they will do a consultation with you. So the consultation will either be a questionnaire or they may Skype a consultation with you or a telephone conversation. As a result of that, the doctor at the other end of this consultation may decide that you can have a prescription for whatever it is, an opioid or a Z drug. That prescription will go electronically to the UK pharmacy. The pharmacy will have the prescription. The prescription will be signed by a doctor who's registered in a EU member state. That means the prescription is legal and can be dispensed against legally. So, everything that's happening through the stages of this business model is operating legally. Now, the website will be hosted in the UK through a GPHC registered pharmacy. The company providing the doctor's service, the consultations and remote prescribing could be hosted in the UK, but increasingly they're hosted in other EU member states. normally Eastern Europe. So the company is registered there and is engaging the services of doctors who are hosted throughout the EEA, because a prescription is legally valid if it's signed by a doctor registered in an EEA country. The prescription goes electronically to the UK pharmacy, they've got a valid prescription and they dispense. Back to the patient. One of the difficulties with all this is that digital healthcare and digital prescribing is becoming more and more common. But of course it straddles regulatory boundaries. The MHRA regulate the sale and supply of medicines. The Care Quality Commission regulate the provision of medical services. So clinics and online services are their responsibility. But this service is operating from an address in Bucharest, for example. So that's outside the CQC's remit. Those services will engage sometimes GMC registered doctors, or sometimes doctors that are registered in any other EU member state, Romania, Bulgaria, they've engaged. But it's a private service and a private company. I don't want you to get the impression this is happening on the NHS, because it isn't. This is a private company, so the patient will pay a consultation fee with the doctor, and then he will pay for the prescription on the private prescription that comes through to the pharmacy in the UK. GPHC regulate pharmacies, and then of course the GMC, if the GMC doctor is involved in this, then the GMC will regulate and control the doctor. But of course what happens is as the four regulators get together and try to get to the bottom of the legislation about digital healthcare in the UK and who does what, which bit of it belongs to who, and tries to find loopholes in the legislation, as to which this is obviously one, then what do? They move their prescribing service from the UK, where the CQC regulate them, to a country that isn't the UK, where a shell company will exist because it is registered in one of those countries, but it's outside the remit of any UK regulatory authority. That's a very quick canter of the business model involved, but it's on the increase, because of course you know as well as I do that digital healthcare is definitely on the increase. The Secretary of State has said, let's do online prescribing and consulting, and that's great because nobody wants to stifle innovation or cost the NHS any more money. But there's a huge difference between me talking to my GP on the phone, which I've done lots of times, to someone going online, getting hooked up with one of those services, having an online consultation with a doctor who's working for a company registered in Romania, and who can tick a box to say, oh, and by the way, don't tell my own GP I'm doing this. So it's a legal way of either getting a supply or supplementing a supply of opiates or many other prescription-only medicines without your doctor finding out. But of course, there's real people and real patients involved in this, and we have had quite a few coroner's inquiries where they've written and said, this man's died because he was found with all those codeine or dihydrocodeine tablets, and his GP did not prescribe them. Where did he get them from? So when we've done a bit of investigation, we've seen that they've been provided through a website by a doctor who's registered and is working for a prescribing service that is out of the UK. And you're talking about thousands and thousands being prescribed in this way. I'm working with a coroner. I can't give you any more details because the inquest hasn't been heard yet. But in this case, this poor person managed to get 3,700 codeine tablets in the 7 months before their death, all of which is legal because they got a prescription from an online service through 21 registered sites and registered pharmacy premises. Here's an example. Website, UK Meds. That's the landing page. Sleeping tablets. View them. If you click that, I want to buy that, you would then be offered a consultation with a doctor. But the way the website's set out, where it is clearly offering sleeping tablets, it's not Ocado's. They are not supplying bananas here, and it should not be advertised in that way. That's something that has to be looked at. It's dispensed, you will see the green cross sign there. It's coming from a GPHC registered pharmacy. And the MHRA logo, can I spot it? It is there because they are complying with the rules on the sale and supply of medicine. So any member of the public would think, yes, that's a safe site, and it is. The activities that go on behind it are legal, but of course there's huge ethical questions in what happens on the site that can prescribe that amount of tablets and the patient's doctor doesn't know anything about it. So that's what happens. How does it work? Choose your treatment, number one. Not what's wrong with you, but choose your treatment, have an online consultation, and the express delivery will happen. We won't go into this, but this is an even bigger problem because across Europe, the laws vary from country to country. Now, out of the 28 member states at the moment, only 6 of us allow prescription-only medicines to be traded online. The UK is one of them, which means, of course, that the other 22 don't. So you get all sorts of complex jurisdictional questions, because I'll just take France as an example. Now, in France, you cannot get a prescription-only medicine online. They don't allow that to be traded that way in France. So what happens? The French person goes onto the UK website, he goes through the process I've just described, the prescription comes to the UK pharmacy, I've got a valid prescription, it's dispensed to the person in France. The French government will then write to us and say, you're breaking the law. One of our citizens has managed to get prescription-only medicines from the UK. I want you to take that website down tomorrow. And of course, I explained to them that I sympathise with the problem because the law has been broken in France, but unfortunately I can't apply French law in the UK because we live in the UK and everything that's happening in the UK is legal. So that's quite an interesting situation. Because in most of the countries, they will write to us all the time and say, you're breaking the law, our people are dying, they're getting prescription-only medicines, and it's your fault. But everything that happens in the UK is legal. It's not legal in the country where the person's buying from. We're going to do the questions later. And that was just a very quick canter through the legal, so we can sort of split up what Owen said about online activity. Most of the websites that will pop up when you say, I want to buy whatever, anything from Viagra to what, most of them will be trading illegally. So sure as fate, if you order a prescription-only medicine from that website, it won't be the licensed version that you will get. And Owen, you described it perfectly. You don't know what you'll get because it'll most likely be an unlicensed generic medicine from the Far East. You don't know what's in it. You don't know what effect that will have on you, long-term or short-term, or what it might be adulterated with. We spend a lot of time at the MHRA trying to warn people, don't buy online unless it's a recognised site, because you don't know what you're getting. We run public campaigns and lots of digital information for people, warning them against the difficulties and dangers of buying online. But some of them are operating a legal system, some of them will put you through a consultation service, and you will get a prescription.
Thank you. You stay there. And then we've got about 15 minutes for questions. Kathy and Owen, please come up and then we can just start off. I think Kathy wants to sit at the end. So can we start off? Does anybody have a question to kick off with? Mary Claire.
Thank you for your fantastic presentations from your audience, Kathy. There's all sorts of stuff in my mind going on. Can I just actually ask about codeine, just a very basic low dose one? Is that okay for women to take period pain?
Well, I think the stuff you get over the counter is largely 8 milligrams of codeine and 500 of paracetamol. And obviously, it helps the healthcare service, as we've heard. If not everybody who has period pain goes to their doctor. And the problem is, though, that certainly, I just shuddered when I heard Owen's case history, because that is exactly the sort of population that people start taking medicines for a fairly legitimate reason. And there seems to be a population of well-functioning professional people, and they start off with taking something like codeine for period pain, and they just feel a little bit better. We all have stresses in our lives, we all have things we'd rather not think about, we have deadlines to meet. And I think it is people who start on those medicines, and then it's kind of, the risk is if you have got things that you want to sort of slightly repress, because then you do feel better, and then it is very, very difficult to stop. And there's a cohort of patients who are very, very familiar from that which Owen described, and they're high-functioning people, they have nothing to do with addiction, they start taking these medicines and actually they feel quite nice, and so they keep taking them again. And it doesn't take long before, if they don't take them, then they don't feel very well, so they keep taking them. And this whole thing of embarrassment and sending relatives to buy and having to have them in the toilet before the next meeting and things, that is so typical. So I think that, and I wouldn't like to say there's no role for opioids in life. There are a small number of people for whom these drugs are life transforming. There's absolutely no doubt about that. But it is about keeping the doses low and having it intermittently. So period pain, if managed properly, you're not taking them all the time. You take a low dose and then you'd have 3 weeks break and then you take it again. And that is probably quite safe. I think the risk comes if you maybe have other issues going on and you find that the codeine addresses those issues, then the driver to keep taking it becomes slightly more complex.
And there was something that was interesting, I think we talked about earlier, which was the speed of the onset of dependency, which I think hadn't been recognised. I don't know if you wanted to say something about that.
I made a comment, and I was just really interested to hear your tramadol story. Tramadol is a funny drug because it's partly an opioid and it partly acts on systems that are involved in antidepressants, so on noradrenaline and serotonin. And dependence on that can happen very, very quickly. So we see people coming in for bunion surgery, they're given 4 days supply. At the end of those 4 days, they feel horrendous when they try to stop it. Tramadol is a very, very difficult drug to stop, and it's probably that dual mechanism of action. But I think, we have to be very well aware of that. I think it probably varies, and there's a whole load of genetic predispositions, social, cultural. So, I don't know whether, Owen, you would say how long you would have to be exposed to codeine, say, before you develop a dependence, but I think it would probably vary hugely.
So the way I try to think about this is it's the features of the drug and then the features of the individual taking the drug. So some drugs, depending on how quickly they get in and come out of the body, have a greater liability for dependence. But also the person taking that drug can have quite a variation. So one of the screening questions we always ask, which I included in my presentation, was, do you have a family history of addiction? So is anyone in your family who's had a problem with alcohol, drugs, gambling, anything like that? And that's quite important because that means they may be carrying some genetic vulnerability to becoming dependent, and there is emerging evidence about the genetic impact. So I think it's about those two things, and about thinking about the combination of both the drug and the person. I mean, the other thing is someone's psychological health at the time that they're using is absolutely critical. Most of the patients I see use particularly opioids, but also benzodiazepines, to escape difficult feelings that they just can't deal with. And that little bit of relief they get in the half hour after they've taken a tablet is gold dust for them. And it is so powerfully reinforcing that you can see why they keep going back to that, because it is just their break from what is often a very, very difficult, distressing life.
Lucy, Paul, Jerome, Lucy.
Okay, so I've got a number of questions. The addiction to the online medication service, is that a face-to-face service? Yeah,
so it's self-referral, so people don't need an appointment, they don't need to be referred. They can just refer themselves and they come in and have a face-to-face
Do you
assessment.
have data from that, about the demographics, and also I was quite interested in the benzos, whether doctors are still prescribing those, because that was something of the 80s and 90s, and I thought that was something they didn't tend to do now. Is that more of an online problem now and less of a clinical fed problem, if you know what I mean?
So we're putting together the data from the first year of the clinic. At the moment we don't have it, but I can share you with it a little bit. So essentially the largest drug group we've seen has actually been benzodiazepines.
Brilliant.
And I think the story we're familiar heard most commonly actually is that someone's gone to the GP, they've been given a small amount of benzodiazepines, and the GP's gone, actually no more, I'm not allowed to give you any more, you can't have any more, you're going to get dependent on them. And people go, well, yeah, but they really, really help. And actually this group are just used to going online and getting things, and they will order cinema tickets, they'll meet their friends online, they'll buy their food online, and they'll buy their medicines online. It feels very normalised for them.
Has there been any moves to make online prescribing illegal in this country? And why not? I mean, it's very difficult obviously to change legislation, but given that we're in a minority of having a legal system.
I think you have to separate the prescribing activity from
online
the sale and
service.
supply of medicines.
Okay.
So, I mean, I said in the UK we allow medicines to be supplied, to be offered and supplied online, provided all the other legal requirements are there. One of them will obviously be a prescription. So if they have a prescription, then yes, that's all legal.
But given the problems that it now seems to be presenting, has there been moves to?
I can't speak about the prescribing, but I would very much doubt if we will go back to not offering medicines online, because it has been that way since the Electronic Commerce Directive. The UK decided we would allow medicines, including prescription medicines, to be traded in this way.
So what other ways, are there other thoughts about how to restrict or close down the site, or close the loopholes really?
Well, I think it's not just about enforcement.
No.
So I'd say one of the key areas here is education. Because actually people like Anna would now look back and say, if someone had been a bit clearer with me and been sort of a bit more direct with me about the harms, I sort of knew them, but I never thought I'd get to this. And I think if there'd been, if we thought about how we educate people to the risks of prescription medicines in the way that we do about illicit drugs, then we'd probably be making more impact than try and control an internet which is almost by definition uncontrollable. So that would be my feeling. Because if you'd asked Anna about heroin, she'd be going, oh my God, heroin, I never touch heroin. And yet she's taking a drug that works on exactly the same part of the brain in exactly the same way. When she stops taking it, she gets exactly the same withdrawal symptoms as if she was taking it.
Paul, any?
Two questions, one for Owen and one for Lydia. First, from what you were saying on the groups, all those groups you mentioned, clubbers and males, males, but so it's quite a younger demographic taking it. But obviously opioids were originally designed for pain relief, which tends to be more in older people. Do we know are there any figures on what the split is between recreational use and the original intended use for pain relief? That was, and for Lydia,
Linda.
sorry, is it? Oh, it's Lydia. Sorry.
No, my typing.
Yeah, sorry. Yeah, you mentioned it there actually, the Electronic Commerce Directive. I didn't know there was one for starters, but why it amazes me that 22 countries in the EU don't allow this to happen, and there's only 2 that do. So shouldn't the EU been doing something about that years ago?
It was left to the member states to decide what they would want, what they would allow to be traded online and what they wouldn't. So that was very much left to them. So the UK decided at that point, I wasn't in the Department of Health at that time, but the UK decided that they would allow medicines, including prescription medicines, to be traded online, along with another 5 or 6 countries.
I thought a directive had to be implemented in every EU country when it's a directive. I thought that had to be implemented, isn't it?
It did, but
so they've still got subsidiarity, or whatever it's called,
they were allowed to make decisions about whether or not medicines would be included in online trade. That decision was left to each individual member state, and the UK said yes, we'll allow medicines to be traded in this way.
But other countries,
said we don't want that to happen.
But they can still access websites in all those other countries through UK websites.
Yes, they can.
And I think there's another element to this. I mean, we mustn't forget that actually there's an enormous potential for online health interventions, and whether it's safe prescribing of medicine, whether it's psychological interventions, the potential around using internet, mobile phones for health is huge.
It's huge.
What we're experiencing is, as with, for example, the internet, it has enormous benefits, but actually there are some dark sides to it as well, and I think that's what we're experiencing as we're embracing this online health agenda. We're understanding that actually we need to think about it carefully because it's got upsides but also downsides.
And could you just address the question about the demographics?
So I don't really know the answer to this. I think we're still trying to understand the edges of where this is. I mean, Kathy, you may know better than me.
There's some stuff from the States that is very, very clear that it is the young population that are the small. I think there's a point that comes out of this that because it has been historically very easy to get opioids, for example, in the States by doctor shopping, pill mills, whatever. There hasn't been a need to go online. But if you look at the figures for online, it's definitely young. It falls off quite dramatically with age. And interestingly, there's some quite clever analyses that show that if older people are buying online, they're much more likely to have problematic opioid use disorder. So it's a high risk population at that end of things. But definitely it decreases. So over 50% of older people accessing opioids in the States will get it from a single physician, like we do in the States. So I think it is, but I think it just reflects the use of the internet as we know it, doesn't it?
Those digital natives.
You need to go on. We've got 5 minutes left, and Jerome wanted to ask a question, and so did Andrew at the back. Jerome, did you want?
Yes, I did. I was very puzzled. I did a little bit of research before I came along here, so it sounds actually useful. And although we've known for a long time about the risk of these drugs, and it was certainly becoming very clear by the beginning of this the last couple of decades, that there were problems in America with OxyContin and also fentanyl. I looked up what the prescriptions were, and in 2004 we were giving 208,000 prescriptions for OxyContin, and by 2016 they'd gone up to 1.5 million. So massive increase, knowing that it was a dangerous drug, high addictive and all the rest of it, absolutely no attempt to make any publicity about it or take any regulation or whatever. And exactly the same thing happened with fentanyl. Prescriptions in 2006, it wasn't available as far as I could see in 2004, and there was just over 500,000 prescriptions. By 2016, there were 1.2 million. So massive increase in these dangerous, risky drugs. You knew bad things were happening with them in America. Why did nobody do anything? We've only got this month, the MHRA is going to look into it and see what needs to be done. Sleep at the wheel?
No, I think that I think there are many sort of complex things there, and I think 2 points I'd make is a lot of the stronger opioid products were only licensed at the beginning of this century, so obviously they take a while to grow market share. I think there's been a whittling away in that therapeutic space. So first of all, we had the issue with COX-2 inhibitors, Vioxx and so on. They were taken off the market. We had the withdrawal of coproxamol because of issues about overdose. We then had concerns about other NSAIDs like ibuprofen and so on, where there was a cardiovascular risk. It sort of doesn't leave much in that space. And I think you then couple that with an increasing expectation of what medicine can do for people. So an intolerance of putting up with symptoms, an expectation that you can go to your doctor and whether it's grey hair or pain or whatever, I want something done about it. And I want it done now, and I want a pill, and I don't want to lose weight, and I don't want to have exercise, I want a pill. So there's a kind of expectation of a pharmaceutical response to a symptom. I think that, again, it speaks to the issue of patients with pain being very distressed and people wanting to do something about it. So there's some really good qualitative research now where GPs are very familiar with the harms, but it actually takes 2 people to generate a prescription. So it's not my doctor made me an addict. It's often those consultations are very confrontational. GPs will say a lot. They feel they're on the opposite side. They feel they're in a controversy with their patients. And as I say, there are a lot of very angry patients who write to the ombudsman saying my doctor wouldn't give me these medicines. So I think it is multifactorial. But I think the messages are beginning to bite. Fentanyl is now going down, and I think if you look at the figures for opioid prescribing generally, they have fallen for the first time in the last data set. The other point I'd make is I once did for a talk I was giving, I put my pin in the BNF, which is our drug bible, and I think I looked up tamoxifen, a respiratory product and a cardiovascular product, and actually they have the same increase in prescribing. So there is a tendency for us to use medicines more and more across a number of categories. I think the problems here, we have a definite public health problem of over-prescribing a range of products for pain, of drugs which have many harms and have very little benefit. And I think opioids are under the lens because of what's happened in the States, but gabapentin, pregabalin cause equal concern now.
Linda, is there something you wanted to add before we must wrap up to Jerome's question about the MHRA only starting their review now?
I work in the law enforcement part. I wasn't at the MHRA that long, but I mean, the press release has gone out about the working group that has been launched under the UK Commission on Medicine. So.
Do you know when it's likely to report?
I think it's this year. I think it's
yes.
I think it's not too distant from the PHE.
From the PHE report.
And can I just make, because I think one problem is, and we've seen this with benzodiazepines maybe, so we had benzodiazepines before that, we had barbiturates, now we've got opioids, now we're going to pregabalin. People want psychopharmaceuticals of some sort, and we go through repeated cycles. What's going to happen with cannabis?
Yeah.
We don't know, but that's the risk. But I think one of the effects that we must be mindful of is that as clinicians become, because clinicians are much more saying, now I can't give you this, or I can't give you a high dose of this. That is when people think, well actually I'll go and top up and go online. And I think that one of the, because it's so easy to do, so we're educating clinicians to be much more cautious and thoughtful about these drugs. But I think people who have them and who maybe find it difficult to stop will say, well okay, my doctor won't give it to me anymore, I'm going to go and get it online. And I think that's, that's a storm waiting to happen really.
Well, thank
It'd be
you.
better after Brexit.
Jerome, we have to leave unless you want to practice your Zumba and stop being annoying. Thank you so much to Mike, who's hosted us. Thank you so very much to all our speakers who provided us with extraordinary insights into this issue, which, as you know, I feel passionately about. So, thank you very much for coming.